So I would like to thank you all for turning up tonight, and I'm sure you are as interested in this subject as I am. It's certainly an area that we meet quite frequently, and probably an area, if you're like me, slightly uncomfortable with and not 100% certain how to deal with. Particularly for me, it's the early emerging people with eating disorders and how to actually best manage them. So I guess I'm really looking forward to this. And I think tonight will be really interesting as well, because we're in the spirit of team care. We're going to have an interactive team presentation. So we're going to have 3 people presenting with a couple of extra people at the end who will actually help us with the LHD information. And of course, you wouldn't see me without hearing about health pathways. So I will be pointing out some of the health pathways that we've been working on. Particularly Mars here from the LHD has been really putting a lot of work into redoing the suite of health pathways that we have on eating disorders, which I shall show you through the evening. But I wanted to make sure that you're all aware that as of this evening, literally this evening, we now have the live, there's not the one I was going to show, the live one for the eating disorders plan. So let me quickly see if I can show you that one. Okay, so this is on the live site. So I'm talking the Sydney Health Pathways, and Southeast Sydney is this as yet have not got any eating disorders pathways. So you're very welcome to use our pathways for the clinical information. Will be the same. Obviously, your referral information will be different if you're from a different area. But this is the eating disorders plan, so a lot of the things we're talking about tonight will be there. So some of the resources and links to some of the places and templates that you will be getting told about tonight will be on that pathway. So we might have a look as we go through the evening. Anyway, I'm very excited to be moving on to this, and I think it will be a really fun night. And it is interactive, everybody, so keep awake.
I'm Jan Orman. I have been a GP at Sydney University Health Service for about a quarter of a century, up until a couple of years ago. I'm no longer there. I have a practice, I rent a room in Rozelle where I see patients with mental health problems, and the rest of the time I'm an educator with the Black Dog Institute's professional education team. So I'm very involved in mental health, and I was very involved in eating disorders treatment for a long time. I've got a master's in psychological medicine, in cognitive behavioural therapy, and a shared care diploma in psychiatry, brackets eating disorders. So they're my qualifications for being here. And I'd just like to say that tonight we're focusing on team management of eating disorders. We want you to go away knowing that you don't have to look after patients with eating disorders all by yourself, because the best treatment for eating disorders is done by a multidisciplinary team of professionals. And we are going to model that behaviour by being a multidisciplinary presentation team. And I'm just going to hand the microphone to Gabby, who is sitting here terrified that I'm going to give it to her. She's only got to talk about herself. I don't know what the problem is.
My name's Gabriella Barclay. I am a dietitian. I've got 8 years of experience working with people with eating disorders. Rachel and I both work at Inside Out. It is Australia's Clinical Institute for Clinical Innovation, Research and Policy. And I've gained my experience in eating disorders working at Northside Clinic on the eating disorder unit and the Butterfly Foundation and in private practice, and now manage a variety of different projects at Inside Out.
So here's our dietitian. This is core team for eating disorders care. GP, dietitian, psychologist.
Hello, I'm Rachel. As Gabby said, I also work at Inside Out in a variety of clinical projects, but when I'm not there, I'm in private practice in the city. I've been working with eating disorders for almost 10 years, in public and private, in Queensland and here in New South Wales. So looking forward to talking to all of you.
Eating disorders. So I was going to next get you to identify your professional group, your discipline. But I've had a sneak peek at the forms you filled in, you signed on the way, and I've discovered that all but 3 of you are GPs. So much for multidisciplinary team care. Who's not a GP? You're a practice nurse?
No, I'm a dietitian.
Oh, how exciting! Dietitian. I can't see you. So
I'm pretty sure.
Anybody else? And a practice nurse. Well, that's very good. Thank you. I'm pleased to see the 2 of you. I wish there were more other disciplines here, but we'll make do without them. as we sometimes have to do. This is a summary of our goals in being here. We really want to improve your understanding of eating disorders as community practitioners. We also want to promote identification and early intervention. Now that's my soapbox. I rather feel that it's too late by the time someone's got an eating disorder to intervene. You all know, I'm sure all of you have had at least one established eating disorder patient in your practices. It's often too late by the time the eating disorder is established, and we need to get better at early identification and intervention. We would like to increase your knowledge and confidence around identifying eating disorders and increase your understanding of the new item numbers that will allow you to feel more confident about intervening early, because there's backup for you. There are other members of the team that can claim Medicare item numbers. So these are the learning objectives, the formal learning objectives, which basically echo what I've said, except that in addition to what I've said, there's Margot's learning objective, which is something about, and I can't see, familiarising you with the new health pathways around eating disorders. I'm sure all of you are avid health pathways fans, and the eating disorders pathway is going to be very useful. This is somebody else's slide.
I just wanted to set the scene a little bit with some prevalence rates here, so excuse all my data. But about 1.2 million Australians are living with an eating disorder, so that's about 5% of the population. There's 1 in 20 adults with an eating disorder. As you can see, the numbers there for anorexia nervosa, and I want to particularly note men who are significantly underdiagnosed, and the rates are on the rise there. So, and up on the side you can see the numbers for anorexia, for bulimia, and for binge eating disorder, which is the one with the highest prevalence rate.
Can I just say that 1.2 million people have an eating disorder, but only 1,900 have anorexia nervosa? There's a big gap there, isn't there?
Yeah.
Whereas we're all thinking about anorexia nervosa when we come here today, aren't we? Oh, sorry.
You're not talking into the microphone yet.
I'm not allowed to talk unless I've got the talking stick. Oh, we could. Okay. But I think that point is clearly made, isn't it? It's that anorexia nervosa does not make up all the eating disorders in the population.
That's one of the myths that we're really trying to address today as well, is that we're not just looking for underweight people with anorexia. There's a whole spectrum of eating disorders across different body shapes and sizes and presentations. Yeah. Highest mortality rate of any mental illness. That's a bit scary. So 450 people are expected to die from anorexia every year. 1 in 5 of those are suicide, and around 200 people are expected to die from bulimia every year. Now, these are just the numbers that we know of.
Something I've read says that anorexia nervosa, the cause of death in anorexia nervosa, the second highest cause of death is suicide. Is that right? Or is it the highest cause of death?
I think it is the second highest cause of death from medical complications.
Yeah. Is it something you think of when you're dealing with patients with anorexia nervosa? Because it needs to be. Yeah. I personally have, unfortunately, experienced 3 patients with anorexia nervosa who have died by suicide. So, I mean, it's very devastating when it happens. You got more to say? Because I want to tell you a story. Now, I think we learn best by hearing stories. As GPs, we hear lots of stories, and the important ones stick in our minds as learning experiences. Holly is an example of somebody who was missed early in the course of her illness. It was possible to pick up the trajectory that she was on 6 months earlier. Holly went on a diet at Christmas time because she didn't want to be one of the fat girls in high school. So she went on a diet in that Christmas between year 6 and year 7, and she was very good at it. She got herself down from the chubby range to a BMI of 22. Now, I don't know Holly at all, but I do know her mother. Her mother was a patient of mine because her mother was someone with quite marked anxiety, an intelligent woman with a history of anxiety, very strongly attached to her children and her children's welfare, who was constantly presenting to her GP with anxieties about her children's health. So when Holly's mum came to the GP and said, "Here's Holly, I'm worried that she's lost a lot of weight over the Christmas holidays," the GP, who also knew Holly's mum and knew her to be very anxious on behalf of her children, said to Holly, "Oh, Holly, what a good job you've done, you look terrific," and sent them on their way. He wasn't prepared to take notice of mum's concerns, and that's message number one. Parents do know about these things. If you put yourself in the parent's shoes, think about how you'd feel if the GP sent you away without paying attention to your concerns. So Holly's trajectory was that she was in hospital by July. Hospital with medical decompensation. She subsequently, over a 5-year period, had multiple admissions to hospital. And to the best of my knowledge, Holly is still not better. So you're hearing the message loud and clear about paying attention, and also about you can get an eating disorder with weight loss from any weight. Holly was outside the normal weight range, up above a BMI of 25 when she started dieting. She was in the normal weight range when she saw the GP, but she's lost weight at such a rate that the GP should have been paying attention. So that's a little message coming from Holly's story. Any comment on that, anybody? I think one of the big problems for general practitioners is our focus on obesity and the complications of obesity. We're busy encouraging all our patients to get in the normal weight range. While we're doing it, we have to be aware that there are some patients who have a predisposition for eating disorders and whose dieting for weight loss will progress to something more sinister. So, early intervention and identification are indeed key, and GPs are in the very best position for early identification. There was some research quite a long time ago that showed that before an eating disorder was identified in a patient, that patient had usually come to the GP, somebody correct me if I get this wrong, 3 times as often in the 2 years prior to the diagnosis with eating disorder related symptomatology. Now that's not really that straightforward. They didn't come with weight loss and amenorrhea. They might have come with a whole variety of other symptoms and signs. But when you look at it retrospectively, you could see that they were coming more often and that their symptoms could have been related to their disordered eating. Good. So people come up with lots of alternative explanations for weight loss and thinness, and here's a few of them. I've had many of them actually said to me in the course of my practice. Do they resonate for you? She needed to lose that weight, was what Holly's GP was saying. Yeah. Thinness runs in the family. We're just fit and healthy in our family. We eat well and do lots of exercise. All sorts of. Anyone got any other thoughts that come to them about things people have said to them about their weight loss or their incipient eating disorders? You guys? Food intolerances, absolutely. I can't eat gluten, I can't eat lactose. I'm allergic to what are those other things? Oh, there, salicylates, thank you very much. Haven't been a GP for a while. It's chronic fatigue. You know, lots of other explanations when in fact what you're looking at and what you haven't dug for is the cognitions that indicate, hey, there's something going on here around this behaviour that's driven by their abnormal cognitions. Here's a whole lot more. So these are some reasons why we might miss eating disorders in the early stages. We don't ask. We don't ask about nutrition. I'm running a big campaign at the moment to get GPs to ask more about nutrition. Would that make you happy, Gabby?
Yeah.
Okay, good. Is nutrition something you talk to people about? When you're busy talking to them about smoking and alcohol and exercise, sometimes exercise, nutrition's another thing. you need to be talking about, and not just for their physical health. There is increasing evidence that poor nutrition is a very big driver for mental health problems, and that you can actually get people better from their depression and their anxiety if you get them eating regularly, yes, eating regularly and eating well. So that's why we all ought to be asking more about nutrition. We don't have to be experts in nutrition, that's what the dietitians are for. But we do need to be able to identify people, including ourselves, whose nutritional habits are not beneficial for their physical or mental health. So that's one big reason we miss eating disorders. And another big reason is that we link in with their thinking about food and body, etc.
When do we call it disease and when is it normal? Where
Well, that's a very good question. Anybody like to answer that question?
I mean, that's sort of what we're here to talk about. I mean, a key thing, if you think about any psychological disorder, is when it starts to really impair function. But what we're talking to you about here is early intervention, is seeing like dieting and body image disturbance being the very key factors for somebody developing an eating disorder. So you should have your flags up then.
And when would you worry about the bariatric surgery happening earlier and earlier, and people have come in even before they're married or have had children and they've already had the bariatric surgery, and they say, so where do you draw the line? This is becoming a norm.
It is, and that's true. And culture,
in my whole practice that way.
and that's the point. Like culturally, we're reinforcing some of these ideas about disordered eating and disordered exercise. Absolutely.
And the real problem is that medical culture reinforces some of these ideas as well. We can fix your obesity by doing some surgery. And the diabetes specialists are encouraging us to think about it that way. But there are other ways we can approach it. And so culturally we're reinforcing some of those ideas in the community.
Sometimes the patients are very hung up on what their diagnosis is and they're really not interested.
Yeah, it's true.
Like
it's
somebody
true.
with major depression, you're doing a mental health plan, you tell them you're iron deficient. So you think it's that, I'm just going to go over to another chick who's going to give me a they just don't want to hear anything you say.
No, but it's partly in the way you introduce mental health diagnoses into the conversation too. You know, I mean, I'm sure you know as well as I do that you need to introduce them up front, not down the line as well, if it's not any of these things, it must be a mental health diagnosis. That's no good. They will think you said it all in their head and go to the next guy along the way. I understand it's a dilemma. It is not easy. But having said that, I also know that we all need to get a bit better at it than we already are. You mentioned paleo and all those fatty kinds of diets. Would either of you two like to comment on that?
I was going to say, I think the one of the things we really want to red flag is that dieting, body image concerns, especially even in children as young as 8, has become kind of a social norm, and certainly I think in our profession we're sort of so sensitive to it, and it straight away becomes a red flag. I think when you are working in a GP practice and obesity is also a key focus, it becomes a little bit harder to always be putting up red flags for eating disorders when there's a lot of other things going on in your practice. I think our aim really is early intervention, so it is kind of having that awareness, being aware of the type of people that come in, that it can go across any kind of age, gender, and Jan's going to go through a whole lot of different interesting presentations of how people might present into your office with it. And really the line gets drawn when somebody is dieting or concerned with their body image to a point in which it's impacting their life. So children are not performing well at school, or they no longer want to socialize with their friends, or people are finding it difficult eating at work or going out for a social drink afterwards. So I think having a comprehensive assessment where GPs are assessing nutrition intake and they're also assessing somebody's thoughts that go along with their eating patterns, that would certainly help to kind of red flag at the beginning of an eating disorder.
I was just going to ask, as we're doing these sort of screening for nutrition issues, along with all the other things that we're doing, do you have any really quick questions and sort of questions that I can fit into my consultation quickly that might give me on nutrition, it might give me the red flags or be worried.
I mean, the validated tool that most health professionals use would be the SCOFF screening tool, and we'll go through that. I would say that would probably be the best one for GPs to use. It's a validated tool that all of us can use. And
Are you all familiar with SCOFF? No. We'll get there in a minute.
We'll get there, yeah.
SCOFF looks at eating disorders broadly, but it doesn't look at nutrients.
No.
You need a much more extensive interview in order to look at specific nutrients.
But at the same time, in the community, when a dietitian is doing a nutrition assessment, and let's say they are a general practice dietitian, so they're not actually an eating disorder specialist dietitian, they're not necessarily, they're there in the same boat, right? They're looking at a whole lot of different things, and potentially the person's come in for assistance to lose weight, and that dietitian is thinking weight management. They're not thinking eating disorder, right? And so I think it's really about asking the questions around their food and how they're eating, and around their food patterns, and around their thoughts and their feelings around their eating patterns, their body weight and shape. They just have to become standard questions.
I can tell you one it's simpler than that, Margot, don't you? And for me, the questions to ask are not, do you eat well? Because you'll get a yes to that no matter what. But do you eat regularly? And what does that mean? How often in a day do you eat? And how much do you eat at those eating episodes? And I use that terminology specifically because meals can be misinterpreted, as can snacks. So how many eating episodes do you have a day, and how much do you eat in each episode? And the other question that's worth asking is, do you delete anything from your diet? Is there a food group or a specific thing that you delete from your diet? Oh, I don't eat gluten. Oh, I'm intolerant of lactose. Oh, I'm allergic to nuts. I'm allergic to green vegetables. I don't like any vegetables at all. I don't eat fruit. You know, you'll get lots of interesting responses to that sort of question. And at that point, that's when your antennae have to go up and you have to ask some more questions in relation to diet. Is that okay?
Yeah, great.
Oh, sorry, Martha, I'm trying to knock you over. Just scream if I stand on you, it's okay. So, I mean, and the other thing that we've got to deal with is our own crazy ideas about nutrition. Who's on a paleo diet here?
Keto's the new thing.
5 and 2.
Yes. Sorry, I'm not up to date. Who's on a keto diet?
Yeah, who's fasting?
You know what? I'm doing intermittent fasting. However, that doesn't necessarily mean I think other people should be doing it, or that I think it's healthy and good. It's just that I'm neurotic, and I won't take lipid lowering drugs, so I'm trying to get my cholesterol down. Okay. We all have silly ideas about things, and some of us have silly ideas about food. Like, I was an intern once. I don't need to eat more than once a day. This is not a sensible idea, but we've all experienced it, haven't we? Yep. Okay, so be careful. Know your own mind. Know the myths that you hold dear for yourself, and make sure you know which ones of those are not based in reality, so that you don't reinforce the ideas that your patients have about their nutrition, the wrong ideas. I'm showing this picture because in my mind, this is what you're imagining when we talk about eating disorders. Is this someone that you imagine? This is a girl called Anna Wood, who, much like Holly, went on a diet at Christmas time, but Anna was dead by July. She's British. I got the picture from the newspaper article about her, which was one of those terrible tabloid articles that like to have a shocking picture and an exaggerated story. However, it's a true story. The point I want to make, and the reason I put that terrible picture up there, is that this is not your typical patient, not the one that's going to come through your door. This is the one you're going to worry about the most, but it's not the one you need to pick up. Anna died. Lots of people with this degree of illness die or get very sick for a very long while, and it interferes with their lives. We want you to pick them up before they get that bad. Pick up Holly at the time she comes in, having lost her weight over Christmas. Pick up Anna when she comes in, before she loses all this weight, when she comes in with multiple colds because she's got nutritional deficits and impaired immune system before she gets down to a BMI of 14. So don't think about all eating disorders patients like Anna. Here are some early presentations that are real presentations in my practice. A lawyer who's an athlete who came in with sore feet during a marathon preparation. She had osteoporotic fractures in her feet. She'd been suffering from restrictive eating for years, and it had never been picked up. Nobody had ever made the diagnosis because she was an athlete. Beware of the over-exercisers. John was a 35-year-old gay man, incredibly fit, came in with reflux esophagitis. John had bulimia and had it for a long time. Very important to him in the culture that he lived in to have a good body. So he was a gym junkie and bulimic to boot. Peter, 43-year-old single mother of 3 who was obese and came in wanting help to lose weight. Did you ask the questions that you needed to ask of her before you gave her the pills or sent her to the dietician? She's been throwing up too. You know, you don't know that unless you ask the questions. Greg was an interesting boy. He was in his first year of uni and he came in towards the exams not being able to sleep. Always been anxious. For all the world it sounded like he had an exacerbation of his anxiety disorder. Until you asked the questions about food, Greg was waking up hungry. He wasn't waking up with his anxiety, he was waking up starving. He'd decided that he could only eat if he walked for an hour first. And that applied to every single eating episode that happened in his life. So it would have been very easy, if I hadn't been preoccupied with eating disorders, to diagnose that as anxiety and treat it as anxiety. Came from an anxious family, all looked pretty straightforward, but in fact, a little bit of deeper digging revealed that he, in fact, was starving. See, lots of people. Mariam, who fainted, 12-year-old who fainted on a sports day, had her periods. No one twigged to the fact that she actually wasn't eating at all. Hillary comes in looking exhausted and pale with a 6-week-old baby. Who hasn't been there exactly? Who hasn't seen lots of exhausted, pale women with a 60-week-old baby? The reason she was exhausted, pale and iron deficient is that she hadn't been eating. Very important to her to get back to her pre-baby body. She'd actually had an eating disorder in her teens, so that wasn't too hard to pick up. A couple coming in for help with their infertility. Dig deep with infertility. Don't send them for infertility treatment if what you've got there is someone who's undernourished and not ovulating. And Peter, what would you think if a 64-year-old man came in with PR bleeding? You'd be doing a stool test, wouldn't you, and sending him off for a colonoscopy. In fact, he'd been abusing laxatives and had nasty hemorrhoids as a result of abusing laxatives, and that's a relatively common thing to happen as well. Am I making you think of people that you might want to go back to and have another talk to about what they've been up to? Okay, so these are my flags, and I'm thinking, I was saying to Margot earlier, I'm wondering if maybe I should change my attitude to vegetarianism and veganism. It's fashionable. Everybody's doing it. Same with gluten and lactose. But I'm just asking you, if someone comes in and says they're vegetarian, make sure they're okay with their body. Make sure you're not looking at someone who's vegetarian for disordered reasons. I mean, I think vegetarianism is an eating disorder, frankly. You got your fingers in your ears? And as for veganism, goodness me. Sorry, just being outrageous. Has anybody taken offence yet? There's usually somebody. Yeah. I don't care if you take offence. So, early clues. Fatigue. Always ask about nutrition with fatigue. Now remember, we may not be talking about eating disorders here, as in DSM-5. We may simply be talking about disordered eating, which we probably all got or had at one time or another. But these are the clues, and this is the time that we need to make these interventions. What else have I got on this list? Irritability. Boy, I get cranky when I get hungry. This has been made common knowledge in the hangry ads for that chocolate bar, hasn't it? But that's one of the early signs of eating disorders. The particularly young women, it'll fool you every time because adolescents are supposed to get cranky, aren't they? So young women who are getting cranky at home, you need to ask nutritional histories from them. Find out what's going on there. May not be, they may just be young women being shitty. But disturbed sleep, unexplained fainting, increased exercise and exercise-related injuries. Beware of that. They'll tell you they're just getting fit. You need to dig a bit deeper to find out about the cognitions behind that. Avoiding social eating, that's a big one. The people who just don't go out to eat anymore, don't eat in public. That's because they don't want anyone to look at what they're eating and make judgments about it. Sure, they could have social anxiety disorder, but it's worth examining a bit more closely. And bowel disturbance, especially constipation, is another thing that you need to keep your eye out for. How do you start a conversation about eating disorders? Do you want to talk about this? You go.
All right, so this is just some basic overview of the types of skills that you might implement. I think it's important to think about the when and the what and the how. It's not, asking someone, do you have an eating disorder, do you have a problem with your body, is probably not going to get much of a response. It's important to realise that a key feature of a lot of these illnesses is ambivalence and a secrecy, whether that be from guilt and shame or whether it be because they're not ready to change, right? They're coming and talking to you about something else often and they're not possibly ready to reveal what's going on with their eating. So it's important how you approach someone. Choosing the time carefully. I mean, it's a bit easier for you guys in your rooms because you're, one-on-one in a private space, but certainly not the waiting room, or maybe not with a parent or partner present. They might not be able to answer it candidly then. And being as open and non-judgmental as possible. So saying what you've noticed and why you're concerned, and just wondering if you're okay. I've noticed that you're exercising a lot more than you would have usually, and it seems like it's very hard for you to not exercise when you've injured yourself. Are you okay? And talk to them as a whole person, right? I know you, I understand what's going on for you in your life. I know that you're worried about things that are coming up with uni. Is that why you've been eating less? And like I said, thinking about the thoughts and feelings about getting help for their eating disorder, because it will fluctuate. Sometimes people are not aware that they have a problem. Sometimes they are aware and they're not ready to do anything about it. And sometimes they just need to hear what their options would be if they were wanting to change.
The biggest advantage we've got is that we can ask anything we like, although it is the way we ask it that's important. And one of the best ways to embed a nutrition history is to say, look, this is part of my normal assessment of people. I always ask people if they smoke, if they drink, how much exercise they do, and what their nutrition's like, because that's part, I think, of assessing the whole person. So that's where this whole thing is much easier for us to do than it is for lots of other people to do in the context that they work. I think it's really important to understand too that maybe not so much disordered eating, but eating disorders themselves are a coping mechanism. They're an external sign of a mental health problem. Eating disorders are unique in the way they are a crossover between physical and mental health problems. They belong with a foot in both camps eventually. And these are what people with eating disorders are often trying to do, is numb painful emotions. Have you heard that before? In self-harm? That's worth... And drug abuse, yeah, all kinds of self-harm. And there are lots of people who think eating disorders are, in fact, for that reason, a form of self-harm. They distract very well from the psychological issues. If you've got someone in front of you who is physically unwell from their eating-related behaviours, it's very hard to focus on their psychological state. That's true, isn't it? So they're a great distraction, and I find a struggle, given that I do mental health work. When I was doing the physical assessment of people with eating disorders, it was always a struggle pulling back to the mental health stuff, because it was a great way of getting out of talking about your emotions if you could get the doctor to focus on your physical health. So it's a distraction technique to some extent. They also provide a sense of control in a life that often doesn't have any control in it at all. I was actually talking to somebody today, a woman in her 30s who's been in and out of hospital since she was 17 with an eating disorder. She's reasonably stable now, but she was still talking about how the way her life feels out of control since she gave up her restrictive eating habits. So it's a way of getting a sense of control over life, which I'm sure we'd all like to have from time to time. It's not comfortable feeling like life is out of your control. And inform meaningful identity. Tell me what that means.
For a lot of people, it's how they build their self-esteem and self-worth. So it's part of them being successful at their eating disorder, potentially having had admissions or groups where they've met other people with eating disorders, talking about their eating disorder with other people, being the person who always stays longest at the gym, or being the person who doesn't eat at a group event, becomes part of like who they are, and it can be quite difficult for them to change, and it might feel like failing at their eating disorder.
What was the word we used to use? Was it institutionalised for those perennial patients? Was that the word we used to use? And it's a kind of eating disorders patients become part of that culture and can't let it go because there's nothing else in their lives.
And it might be attached to their values. So it might be a value of health initially, and then it gets drilled down into, I need to lose weight in order to be healthy. And they've sort of lost sight of actually it's not really attached to health, or being attractive and likeable to other people might be the value, and they're trying to fit in, but it's gone much further than that.
A lot of parents of patients with eating disorders say, my girl, boy, was perfectly normal, had nothing wrong with them until they got this eating disorder. And I have to tell you, I view that with a great deal of distrust. The eating disorder is a symptom of some underlying psychological distress. Now, it may only be like Holly, who was distressed because she was fatter than she should have been, or she felt, and she was getting a bit teased at school for being a fat girl. But that's the distress that provoked Holly. It was enough. Is it a problem her mother? Isn't all of our problems our mother?
A mother who is so obsessed, anxious and difficult, who you knew as such, who would create in Holly the same anxiety all her life, which would make her even more anxious.
Actually, you know, I wouldn't put it quite like that, to say that Holly's problem was her mother, but I would say that anxiety disorders run in families, and anxiety is often an underlying problem with an eating disorder. The thing about being very thin, particularly anorexia, the thing about being very thin is you don't feel your anxiety anymore. Lots of people, when they get back into normal weight range or just below normal weight range, their anxiety starts coming back. So that's when we have to intercede and treat them for their anxiety, isn't it? Yeah. So, yes, there's an element of the environment acting on Holly. You were.
But it is,
Yeah.
if you're brought up in that environment
Yep.
all your life, there's no question that you will end up with issues and problems.
Anxiety-related problems, not necessarily an eating disorder, though. There's no question about it. An anxious family environment leads to anxious children. And often, and this is an aside, that anxiety is normalised within the family. It's not until very late that people realise that what's wrong with them is that they're anxious. So, You want to have a look at the quiz? Gabby says you need to have a look at the quiz at this point. I'm not sure why. There must be a question on it that's related to this. Well, I did point it out to them at the beginning. Yeah, I said to them that they might hear the answers during the course of the presentation. Yeah, yeah. Some of the answers we've just given them, haven't we? There might be some myths and misconceptions on the quiz as well. See, I just want to point out to you, who asked that gross question, made that gross comment.
Yeah.
Sorry.
That's right. But I mean,
See that? Families are to blame for eating disorders.
no, I don't mean there's a blame, but she would have an element of
Yep.
OCD.
Yep.
She would have anxiety. She would have been
Yep.
depressed.
You're right.
She wouldn't have been successful because mother would be constantly on.
Yep.
And then mother comes and says, I'm worried
Look.
about her losing weight and not thinking about anything else.
The one thing that you really need to keep in mind is that the onset of eating disorders happens with a trigger, but people are vulnerable to eating disorders for multifactorial reasons, and one of them is the family environment. There are genetic reasons why some people are vulnerable to eating disorders. Now, I have to tell you something. Holly was vulnerable partly because her mother had had an eating disorder in her teens. That GP didn't know that. And that's also why her mother was anxious about the likelihood of Holly having an eating disorder.
She didn't tell her GP.
She didn't tell the GP. Okay, yes, there are two sides to that. She didn't tell them, or the GP didn't ask? No, but let's blame it all on the GP. That's a good idea. Some people believe that eating disorders are all about vanity. Okay, so sometimes they might start out being about vanity, but not everybody who goes on a diet to lose weight gets an eating disorder. Only a few people do. And those few people, the vanity bit gets lost very quickly in there because they get taken over by a whole lot of other reasons to keep up that. All right, 1.2 million Australians, but not all of them have got anorexia. Only people who are underweight can have an eating disorder. I think that we've blown that one out of the water already. Eating disorders are a cry for attention from someone going through a phase. In other words, they'll get over it. What do you think about someone making a cry for attention? Attention-seeking behaviour. What's your response to that phrase? They need attention. Perhaps we should give them attention. Perhaps not in the way they want it, but perhaps the kind of attention that we're prepared to give them will meet their needs. I don't think attention-seeking behaviour is a pejorative phrase at all. I think it's just a truth. People indulge in attention-seeking behaviour if they're in need of attention, and it's our job to give it to them, but maybe not the kind of attention they want. What's this slide about? This is not my slide.
This is about the function of an eating disorder, and it's a bit about what we were talking about before, that really people are not necessarily have their eating disorder to lose weight. It goes much deeper than that, and in fact the eating disorder often serves a really important function in their life, which is why people are often resistant to changing. So these are some of the ones that we've had patients, talk to us about. So it's my best friend, it comforts me. So it's a set of rules and structure for the world that helps me make sense of things and helps me feel like I'm achieving goals. It helps me to feel good, so that catharsis, like self-harm, so purging or binge eating might be a really good way of getting pleasurable emotions or calming down negative emotions. Protects me from sexuality or from relationships. So I've certainly had patients who haven't wanted to mature physically because they're concerned about how they'll be looked at. No one else can change it, so this sense of control, and often for people who are quite passive and people-pleasing this is their rebellion, or the one thing that they have that they feel like that other people can't change.
Because the rest of their life is meeting other people's needs.
Yeah, exactly.
So this is the one thing that meets their own needs.
Keeping my parents and family close. So like Jan was saying, attention seeking, in that, people show care and love for me, and it comes out from, I guess, not being able to communicate, hey, I need care and love, with their words, and instead they're physically doing that with their eating disorder, and a whole plethora of other things. And I think that's why we're sort of talking about, it's not about vanity, it's not about Instagram, it's not about looking good to the world, it's actually about all these unmet needs that they might have.
So the wanting to look good to the world maybe a very passing phase early in the evolution of the disorder, but then all those other things take over, not least of which is that incredible euphoria you get from starving. Anybody been on a diet lately? I know in this context you're not going to admit it at all. But about day 3 you start to get on a high. I remember it. and you know, those of us like me who aren't vulnerable to eating disorders can't maintain it. But the people who are vulnerable can maintain it, and part of the reason they can maintain it is the euphoria. Let's talk about somebody, because I think it's much more helpful to talk about somebody in particular. This is a 19-year-old woman who's come to see you about her sore throat. Nothing very alarming in that, I suppose, really. It's winter, and this is her 3rd cold in 3 months. 2 months. Are you worried about that? If she's had 3 in 2 months? Nah, happens all the time. But her tonsils are red and swollen, and she's got tender glands and a fever. I'm not even worried about that, are you? No. Okay. But she does mention that she's anxious not to be sick for her sister's wedding, which is next weekend, and she's maid of honour and needs to fit into the dress. Would that spark a conversation for you? Would it? What would you say? Anybody got any suggestions about what they'd say at this point, where Lauren says she's... Say that?
Quite common. A lot of women are worried when if they're getting married or going to important things, how they look, that they want to look good for the wedding.
So it's normal. Okay, so would you then have some more conversation about it or not? If you were going to have some more conversation about it, what would you say?
Why are you worried? Do you feel that you're overweight, or is it an old dress that you try to fit in, or is there a reason?
So you might ask some more questions about the dress. Yeah. Anybody else got any suggestions as to what they might say? Margot, you might have something to say about this, having had a wedding in your family recently.
Oh, and the same family as you. But anyway, that's a by the by.
Her daughter married my son just recently.
That's right.
Isn't that wonderful?
Isn't that sweet? And yes, I did go on a diet before the wedding.
Oh no, that's not what I wanted
But
you
I
to
didn't
say.
get euphoric. I think I missed out.
I wanted you to say what you'd say to Lauren.
I think I'd be asking her what has she been doing to help fit into her dress. So has she had to work hard, and has she been looking at her diet and exercise to try and fit into that dress?
Okay. So you might dig a little bit deeper and ask a few more questions. Oh, where? No, you don't want to add anything to that? So I think the bottom line of that little exercise is that it's probably appropriate, maybe not to dig very deep in response to that, but to dig a little bit deeper. And you're right, it is normal. Margot and I both went on a diet. Margot was more successful than I was, and we were only mothers of the bride and groom anyway, so it didn't matter. But you're right, it is kind of normal behaviour for people, but it's the way they do it. Now, it turns out Lauren, if it turns out Lauren has lost a lot of weight, would you ask about how much weight she'd lost to fit into the bridesmaid's gown? Might be a good question to know the answer to, wouldn't it? And how long she'd lost that weight over, because that's important as well. So she does admit she's been restricting her intake since Easter. Now that's a movable feast, isn't it? No pun intended. Easter sometimes is in March, and sometimes it's the end of April, and we're now in the first week of June. Let's take a middle ground and say it was the middle of April that year. So 2 weeks in April, a week in May, and a week in June. Have I missed out a month or anything? No. 4 weeks in May. Yeah, so that's 6 weeks. All right, she's lost 5 kilos in 6 weeks. Anyone worried? Let me talk to a dietitian about that.
Yes, I'd be very worried.
Why are you worried about 5 kilos in 6 weeks? I'd love that.
I think serious intention has gone into losing 5 kilos in 6 weeks.
Yeah. Someone said, what's her BMI? It's 22. That's a question for you. Does her BMI matter?
Does the BMI matter?
Does that rate of weight loss, does the starting BMI matter?
But does it change the types of questions that you ask? Like, does it change what their intention is or how they lost that weight?
That's what we asked about the BMI. That's what you're supposed to do once a year. Check BMI.
Mm-hmm. So Lauren's gone 5 kilos down to a BMI of 22. Is there half a chance she started in the normal range?
Yep.
Yep. Even if she didn't, you need to worry about that rate of weight loss. Perhaps not, Jane, if she's 100 kilos. It's easy at 100 kilos to lose 5 kilos simply by not drinking water.
But it does depend on the severity of what they're doing to lose that 5
Yeah.
kilos. So whether they're 100 kilos or 30 kilos, if they're
If they're starving themselves,
starving for long periods of time, then we would be worried.
that would still raise a red flag.
Compensatory behaviour is the real red flag. If you are restricting, that sort of weight loss is probably dubious in concern if you're 100 kilos. It's a lot in concern if you're down here where Lauren is. But if at 100 kilos to lose that weight, you're also vomiting or taking laxatives or diuretics, you're in real trouble.
But even if someone at 100 kilos is trying to lose weight or they're trying to manage their weight, you'd still be interested to know how they're doing that and whether they're doing that through healthy practices or whether they're doing that through disordered practices, right? Because ultimately, if they're starting off doing it through disordered practices, that's going to escalate quite quickly.
Now you know that about Lauren, what are you going to do now? Now you know she's lost 5 kilos in 6 weeks and her BMI is 22. Are you going to do anything else?
How much does she intend to lose to fit into the dress?
Say it again.
How much does she intend to lose of weight to fit into her dress?
That's a good question. What's her goal? What's the relevance of that? As it happens, next weekend is the wedding. And she's really upset because she hasn't lost more weight.
I mean, I wouldn't, as a dietitian, I wouldn't necessarily be interested in their goal because what ends up happening ultimately is goals shift and the goalpost constantly moves. So generally what you see is somebody wants to get, let's say she started at 65 kilos and her goal was to get to 60 and then she gets to 60 and then she's like, oh, well, I'm at 60, like now I'm going to get to 58 and now those eating practices have become really embedded and they're starting to be really easy to do and the weight is coming off quicker and then 58 moves to 56 and so the goalpost keeps shifting, and ultimately
It happens.
the goalpost doesn't matter, it's the eating practices that matter.
So the goal weight may or may not be a useful thing to ask. Yeah. So are you worried about Lauren at this stage? Are you going to send her straight to a dietitian and a psychologist? Are you going to send her to a dietitian? Are you going to wait until after the wedding? Are you going to see her again after the wedding? Maybe that's, yeah? Seeing her again after the wedding is probably the minimum action you need to take. Oh, that's a good question. Is she actually going to come back after the wedding? What if you said, it might be a good idea to talk to a dietitian about this weight loss, i.e. she might be able to help you lose some more. Is that?
Way to set expectations, Jen.
I'm sorry, that's probably unethical behaviour. So what I'm hearing from you lot is that you probably wouldn't be sending Lauren to a dietitian at this stage. Is that right? What do you think about that, Gabby?
You guys, sorry.
I was just
What do you? Oh, there's no time before the wedding. Let's push the wedding back a couple of weeks, shall we?
I think a really important message here is even if you only see this person for this one session, there's something that you can do and you can plant a seed. You can say what, you can give them some education, you can give them some, direction, you can be supportive, and they come back. It's surprising how sometimes people go away for years and come back and say, I thought about what you said and I'm ready to do something about it now. And it feels like whether we work in primary care, in emergency departments or wherever, that we just see this people coming in and never following through. But actually, the longer you work in the field, the more you realise people do take that on board. And when we see someone, they've seen a lot of GPs, as Jan was saying, by the time they get to us often.
Or the same GP lots of times.
Or the same GP lots of times. But it is important, even in that one session, to do what you can to plant a seed for someone.
I think the really important thing with Lauren here is engagement, not getting her offside. So it may not be a good idea to tell her that she must not lose any more weight. That might just get her offside. But it might be a good idea to say, hey Lauren, because you've been doing a bit of restricting and losing some weight, we may need to look at your general health parameters, and maybe after the wedding, how about coming back, we do some blood tests to see what your iron's like, what your folate's like, you know, whether in this restrictive phase of your life you've actually been nutritionally well cared for.
Did you give her a form before she goes?
Absolutely. Very good, Tony. I think that's a great idea. This is a distinct advantage that we have as GPs. We organise the blood tests and get them to come back for results after the wedding, as it were.
Can I ask, how do you weave in the diuretics and the laxatives? Do you find that direct questioning gives you that, or would they admit it freely, or would they lie about it?
What's everybody's experience? Have everybody had experience of talking to people about laxatives and diuretics? No, not so much. Not so much. My experience is they tell me the truth, but yeah, you know, I will say, you know, lots of people in this situation try and lose weight by opening their bowels more often or getting rid of the fluid in their bodies by various means. Are you doing any of that stuff at the moment? You know, it's always good to use that third-party style of questioning and normalise the behaviour within the context that they find themselves in. It may not be normal behaviour, don't get me wrong, but you're normalising behaviour in their context. So that's...
Are we teaching them techniques by planting it in that way, right?
No, I don't think so. Nothing they can't learn on the internet.
Techniques online, yeah. I think the other thing also with asking questions about eating disorder behaviours is that if you're asking them questions as part of like a general history taking, then it's almost like a checkbox list of things. You know, do you take any diet pills? Do you take any laxatives? Do you take any diuretics? You know, have you ever self-induced vomiting to get rid of your food or calories? You know, and so you kind of go down the list. And if you are asking the questions from a non-judgmental way, there's no shame attached to it, and in a way like you've seen it all before. You know, which you have, then people will tend to kind of just go through and answer.
Actually, on that subject, we all need to start saying to people, for a whole range of reasons, do you take any over-the-counter medications? We know about your prescription medicine. Do you take anything over the counter? Do you take any health food preparation? We all know about the interaction between St John's wort and SSRIs. You know, if we don't ask about the other stuff, the stuff they buy from the health food store or for over the counter at the pharmacy, we don't pick that kind of thing up. So embedded within that more general history, we can ask the questions about diuretics and laxatives. Wait.
Is it a little bit like asking about smoking, that just asking is the intervention and assessing whether they want to change, and if they don't, just leaving it at that for now with 1 or 2 points? I mean, I'm talking about motivational interviewing.
I don't know that there's any clear evidence that, like smoking, the more you ask, the more likely it is they're going to give up. I know that evidence exists for tobacco. No, but it does say ask. It doesn't.
I think you want to ask, and in that initial appointment, or even in your initial 1 or 2 appointments, and the same goes for a dietitian's initial sessions as well. You're thinking engagement, like you want to collect the data, but before that you're trying to engage the person. So it might be that only the next time you ask those questions, if it doesn't seem appropriate or it seems like you're going to get them offside in that first session. You know, you want to engage with them so they feel comfortable coming back to you and they don't think, she was judgy, I'm not going to her, I'll find someone else.
Gabby, if Lauren agrees to go and see the dietitian, how do we find one?
Right, do you want to click to the next slide? So Inside Out, on our website, we have a treatment service database. I've just done a little screen grab here for you. Up here we've got filters, so we've got service types. So you can actually click there for a dietitian, a psychologist, You can click there for public or private hospitals. So any eating disorder service for your patients or for your clients, people have registered on our website, and it's national, so it is across Australia. Their little face and icon comes up, and if you click into it, it gives you details about that person and where they practice and their contact details and a bit of a blurb. In order to go on there, and any GP that wants to go on there can, and any health professional can, so it's not a regulated, I guess, service. We try to make sure that people are registered with either the Dietitians Association or AHPRA.
But there's no guarantee that the dietitians on there are dietitians with a special interest in eating disorders?
Generally speaking, people who register on our service, because we are an eating disorder institute, are health professionals who want to take clients with an eating disorder. So they generally do have a special interest in eating disorders. It also shows on there the number of years that they've practiced in eating disorders. They also, we ask them to do a sign-off tick that if they are a psychologist or a dietitian, that they are engaged in supervision, clinical supervision for eating disorders. Yeah.
There is a need that the dietitians that you refer to and the psychologists that you refer to for eating disorders have special interest and training in eating disorders. It's a big mistake to refer someone that you think might have an eating disorder or even disordered eating in the direction of an eating disorder to a general dietitian who doesn't, or psychologist who doesn't have the special skill and training.
Does the website indicate if those practitioners are registered with Medicare?
No, but if they're accredited practicing
Yeah, if they're accredited practicing dietitians or psychologists, they will be registered with Medicare.
Okay, but
there's no one.
it doesn't. Aren't there any dietitians and psychologists who aren't registered with Medicare?
Well, if they're accredited.
That's what accredited means, isn't it? That they're registered with Medicare. Yeah.
And they have to be members of. They have to be like a registered, an accredited member with their professional disciplines body.
What about the EPC access to the care plan? Do they have to be registered with Medicare?
Yeah, they do. Yes. Yeah.
But are you
Yeah.
saying that all the ones that you've got listed
Should be registered with Medicare. Yeah.
Yeah. Yeah. And if you don't feel comfortable assuming, you could always ring them up and see. Yeah. Margot, does Health Pathways fit in here at all?
We might leave it till we start talking about
Okay.
some of those.
Okay.
Yeah. And I think just to reinforce what Jan said, I think dietitians get very little training at university in eating disorders. It's definitely got to be an area of special interest where somebody goes and they specifically do further training and professional development in that area. And like any specialised skill, it takes years of training, practice and clinical supervision. So we really do recommend that if you are red flagging someone with a possible eating disorder or disordered eating, that you actually send them to somebody who has the skills in that area.
And I don't know if you've had this experience or not, but I've had the experience of someone going to a dietitian, sorry Gabby, sorry, who is... No, well, yes, actually there are stats about dietitians with eating disorders, it's true, but a general eating disorders dietitian and general dietitian, yes, and getting, even though they've got an eating disorder, getting advice to remove things from their diet like gluten and lactose. And I know I keep being on about that, but yeah.
I just wanted to make the point, so at this point we haven't actually diagnosed them with an eating disorder. That's,
No.
I guess, an important point, isn't it? That we can actually get in early.
Yeah, that's the thing about Lauren. She hasn't got an eating disorder yet, but there is room to intervene here and now by taking a nutritional history, by getting her to come back so you can talk some more to her about nutrition, and so you can encourage her to go and see the dietitian. And what would the dietitian do?
So if they are specialist dietitians, most dietitians in the community setting will work from a framework whereby initially, kind of like we spoke, engagement is that key focus, and working from a client-centred approach to not get the person offside right from the beginning. Doing a comprehensive assessment, that might take a few sessions to get all the kind of necessary information going at the client's pace. And then Dietitians would generally kind of work in a bit of a phased approach. Our ultimate aim is to get somebody to get back to listening to their hunger and their fullness cues and eating intuitively, but it takes a bit of time to get there. And initially, depending on what the patient's symptoms are and what their eating behaviours are, most of the time we'd start right at phase 1, and that's eating regularly and eating enough. And that goes the same for somebody who is binging, someone who has binge eating disorder, bulimia nervosa or anorexia nervosa, or is actually just engaging in disordered eating practices, is actually just making sure that they're eating regularly and eating enough, and that might be just eating their safe foods. And then from there we sort of would start to go and introduce challenges or eating out or foods that they're fearful of eating, and so kind of treatment progresses. So at the very beginning I would say that as a GP, a nutrition message to take out of it would be starting off by encouraging your patients to eat what they feel comfortable eating and eating more of it and regularly throughout the day.
Don't miss meals, and there should be 5 eating episodes a day. That's right, isn't it?
I mean, they can have 3 meals, 2 to 3 snacks. That would be a good start.
I'm terribly excited about 5 eating
but
episodes.
that might take a while to build up to. Yeah, it depends where they're at.
Right.
You know.
Okay, fair enough. Let's talk about monitoring weight, because this is a big problem. Lots of people don't wish to be weighed. I remember going skiing, and before I understood why they weighed you to fit the skis, I'd just lie about my weight because I didn't want anybody to know how fat I was. Not that they couldn't look at me and see, but weight is a very sensitive issue for lots and lots of people. So weighing can be a really sensitive issue for someone with an eating disorder.
And I think it's considering what impact weighing has on your client. So even what response you have when you've weighed your client, you know. So you might want to weigh them as just part of your general data collection, or maybe you're doing that at your, before the wedding and the after the wedding weigh to seeing sort of what's happening. But your reaction, your facial expressions, and what you say will have a lasting impact on the person. And will also change what the person says to you afterwards. So if you actually keep your mouth shut when you're weighing them and ask them how they feel about their weight, they'll give you a lot more information than if you say, oh wow, like that's really gone down, or like, oh,
that's really good, you've gained a kilo.
Yeah, great job, you know.
That's a significant amount of weight.
The really important thing with Lauren is if you're going to send her to a dietitian at this stage, you talk to the dietitian about who's in charge of weighing her. That sound fair?
Yep.
Yep. So I would include in my referral some comment about I'll weigh her, or you can weigh her. It's usually you can weigh her because it interferes with the relationship that I have with the patient if I'm the one that's weighing her. Then we would make an arrangement to communicate the weight to each other. Now, what I do with the dietitians that I refer to is that I give them my mobile number and they just send me an SMS with the patient's initials and the weight and the date that they've done it. They usually send it straight after they've weighed them. And that gives me all the information I know, and it doesn't have to be shared with the patient. I know Steph's got a story that she'd like to tell about the dramas of weighing someone. You don't want to tell the story? No. Okay, go.
I see quite a lot of patients with eating disorders and have one who was very unwell for, used to see Jan as well, for a very, very long time. Who had been weighed by me, but blind weighed, which worked quite well. So she would turn around on the scales. I never made any comment, didn't have to just remember the number in your head until she leaves the room. Don't write it on a piece of paper unless you put that piece of paper in your pocket or something. Who then went to a clinic for endocrine care because she also has osteoporosis, and had a terrible experience there because she was weighed in the clinic, loudly announced to her that how much weight she had gained, which was a significant amount. Who then clinic also encouraged her at how great she looked because now she was in an almost normal BMI range. I'm fat, yeah, and it was devastating to her. She was in tears with me basically after that, clawing at her skin, saying, I just, I feel so much worse now because I can't even do my eating disorder well. That was the only thing I was good at.
So there's lots of lesson to be learnt in that little story, but the reason I got Steph to tell you the story is that it illustrates just how sensitive people can be about their weight, and just how sometimes, whilst weighing them is a non-negotiable, they can't not be weighed because it's the only way the team that's looking after them have a clear idea of what's going on for them. Telling them their weight is not absolutely necessary, and that can be negotiated amongst the team members.
I think also it's important to add that some patients don't need to be weighed. So does anyone have kind of input on like what type of client doesn't need to be weighed? Like where are we weighing clients where we don't need to be weighing clients?
Well, if you are GP, you're supposed to do that once a year. I just can't see any problem with that.
Well, weighing someone once a year is different from weighing them every time they come and see you, though, I guess.
So as part of a general health
check.
screening once a
Yeah.
year, yeah. Yeah,
But as part of every time they come in?
no. Once a year. That's part of the accreditation.
So maybe you wouldn't
Yeah.
weigh someone who was very fat?
So I think this is these are kind of the points to consider is what is your rationale for weighing and what is the rationale behind how you weigh them, and that really needs to be a discussion with the client. So as a dietitian and in therapy, sometimes knowing their weight and seeing their weight can help them kind of manage or is part of their psychological treatment in CBT, for example. For other patients, seeing their weight and knowing what their weight is doing, especially if they're seeing their psychologist or their dietitian on a weekly basis, seeing what their weight is doing every single week can actually impair their progress and can impair the way that they are going to try and meet their goals that week.
Reinforce their disordered behaviour even.
Can certainly reinforce their disordered behaviour. And for other patients, not getting on the scale or getting on the scale is not as important. So somebody who is within a normal healthy weight range, who is perhaps engaging in, has binge eating disorder, is regularly seeing their GP, is seeing their psychologist, seeing their dietitian. There aren't any extreme concerns about their weight. They've had their weight checked maybe at the beginning of the year or 2 months ago. They don't need to be weighed every time as part of treatment. It's really not relevant.
But the bottom line here is that if someone is in the category of needing to be weighed, they need to be weighed by someone, and that information needs to be communicated to everyone in the team. So there needs to be communication within the multidisciplinary team so that everybody knows what's going on.
So generally speaking, if there's a dietitian or a specialist eating disorder dietitian on the team, the dietitian would take responsibility for weighing, as it really impacts the goals and the outcomes of every single session. So I would say the dietitian generally would weigh the patient or the client and then communicate that with the GP and the psychologist. And really that level of communication depends on what kind of communication you've agreed on. So it was something that Jan and Rachel and I were speaking about when we were doing the presentation, is that psychologists and dietitians will often text each other, and Jan was saying she likes to be texted, and we were saying like we find it quite hard to get hold of GPs' numbers to text them. Like I don't think every GP wants us texting them their clients' weights. So I think some level of open communication within the multidisciplinary team when you are looking after someone with an eating disorder, as that level of communication really does need to be quite regular.
So what's your preference? Anyone text like I do to the various members of the multidisciplinary team, or you're all quite emails without identifying patient details? Yeah, initials, right. Any other method of communication that you use? You really need to think about it, because it's different for everybody. And the great frustration for allied mental health practitioners altogether, is that many of us have reception staff who will not pass on messages and will not let the practitioner talk to us. And that's not okay when you're working with someone who needs multidisciplinary team care. So you need to solve that problem. Okay, I'm only up to part 2 with Lauren, and she's got 4 3/4 parts, so let's go. Okay, the dietitian's come back. It suggested Lauren come back for review, and Lauren's told the dietitian that she's purging as well. Are you worried yet? Yes. Okay, now where our level of concern is increasing. We want to just quickly look at the SCOF, which is the screening questionnaire that we talked about earlier. This is the SCOF. It's easy to find on the Health Pathways site, and it's just 5 simple questions that help you screen for an eating disorder. Do you make yourself sick? Do you worry you've lost control over how much you eat? Have you recently lost 6.35 kilos? It doesn't roll off the tongue, does it? In a 3-month period. So Lauren has already met that criteria for the SCOF. Do you believe yourself to be fat when others say you're too thin? And would you say that food dominates your life? So 2 yes answers to that question, and I've just failed the SCOF. So I'm not going to tell you what my answers were. And there are 2 other questions for bulimia. Are you satisfied with your eating patterns, and do you ever eat in secret? And these are really good questions to ask people to help screen for eating disorders. Laminate that and put it up on the wall behind your computer, because it's something that you probably need to remember. There's one other question that I find very useful to help tease people out, and that is, if there's anything you could change about yourself, what would it be? Just a simple screener, but it gives you some clues about how that person is feeling about themselves from a physical point of view. Okay, I'm not going to go through the DSM-5 criteria for eating disorders, because I'm sure you are all familiar with those criteria. However, I just want to point out to you that there are several eating disorders. There's not just one eating disorder. Several of them are restricting disorders, but some of them are overeating disorders. And all those obese people that we're also worried about, many of them have binge eating disorder. So we're not talking about them. How do you find a psychologist? Do you go to the same website, the Inside Out website?
You can in fact go to the Inside Out website. There's also some great lists with ANZAD, our Academy for Eating Disorders in Australia and New Zealand, and another one with the Butterfly Foundation, although you do need to call their number to get a list of practitioners. Similar to the dietitian, psychologists don't have, as part of their basic training, much information about eating disorders, and you really want to engage a specialist. And with the new Medicare items, which I'm about to talk to you about, there are specific treatments that psychologists need to be able to provide under those numbers if someone's going to have an eating disorder plan. So that's worth thinking about as well. All right, this is a lot of text, so I'll try not to bore you too much. On November 1st, there was a suite of 64 new Medicare items. Do all of you know about that? But I'll just talk briefly about it, but there's certainly lots more information that we can give you. The important part is it sort of maps in a similar way to what we were already doing with the mental health care plan, except we have more sessions. So 40 psychological up to 40 psychological sessions and 20 dietetic sessions. This time it's over a 12-month period rather than a calendar year, just to make life really confusing for all of us. Previously, people with eating disorders only had access to that up to 10 psych sessions in the mental health care plan and 5 dietetic as part of the chronic disease management plan. But what we know from our evidence is that treatment requires 20 to 40, up to 50 sessions for people with eating disorders. So this is really trying to meet that adequate dose. And what we know is that when people are able to get access to the adequate dose, that they have reduced rates of repeat hospitalisations, they have improved health outcomes, and they have less of an impact on our health systems. Multidisciplinary management is built into the items in terms of encouraging this multidisciplinary team that we've been talking about, but I'm aware that there isn't any new items for things like case management, so a lot of us are doing, I guess, extra work when we're coordinating with each other. But as Jan was talking about, I think when you get clear on your roles and you're talking to each other in a way that you all want to correspond, it's actually helping you out. I feel like when there's a dietitian on the team, I don't need to spend my session talking to someone about food and checking in with what they ate. Talking to the psychiatrist or the GP means that we all have clear guidelines, and we can refer to the specialist in each area. But there is a lot of emphasis in these new items on the multidisciplinary.
So there's one new GP item number, and that's the eating disorders treatment plan.
Yes.
And have you got something on a slide?
Well, Suzanne, this might be a good moment to pop in and show you
Okay.
the plan on health pathways. I'll just show you.
So and you've got a copy of the eating disorders treatment plan on your table, as I said before. But on Health Pathways, Margot has a nice digital version.
Yeah, so the template was designed with Inside Out, and we've got it here on your Health Pathways. It is actually designed in an RTF format, so you can put it into your practice management software, or you can also have this printable version that you have, where you can fill it out however you like. Yeah.
And this plan triggers availability of the eating disorder related psychology and dietetics.
One plan, 2 referrals. It's, yeah.
So if you have, do you want to talk about it, Margot?
I was saying that we'll hopefully successfully put on this one pathway all the steps that you need to do to actually qualify, get the patient to build this item number. So on the same pathway, you'll find all the questionnaires that you need to do, ensuring that you know what the restrictions are. So we've got the patient eligibility up here. And we've got the item numbers down here, as you can see, plus links to all the templates that you need. So the templates that are actually on your table are the ones that we link to there. So hopefully, and the questionnaire, so hopefully you find all the things that you need to do, and it explains it. So there are 64 item numbers, but there aren't 64 item numbers for us.
There's only one for us, isn't
Yeah, well there is the
Review, there's a review.
yes, so we've got a review item number,
as well.
plus we've got an item number that is based on, it's time based, and whether you're have mental health training or not. So it's very similar to the mental health treatment plans and same time based thing. So there's really only 5 that you need to know, and they're all just there on the health pathway.
So once you've filled in the plan, and we'll tell you about patient eligibility for the plan in a minute, what that gets your patient is 10 sessions with the psychologist, then a review, then another 10 sessions. Sorry?
We've got a slide about this, Jen.
Oh, I'm just going to stop talking. I'm sorry.
Yes, so I'll talk you through some basic parts of the plan that are important.
It's just that we're short of time.
Yes, I know. We're gonna speed through these because it's legislation. It's a bit dull. There's lots of fact sheets and things available for you. Next slide, please, Jen. So this is eligibility criteria. So what you should know is anorexia nervosa is automatically eligible. Don't worry about the rest of the eligibility criteria. If someone has a diagnosis of anorexia nervosa, they are eligible. That's then or. Patients with bulimia nervosa or binge eating disorder need to have their behaviours, binge eating or compensatory behaviours, at least 3 times a week and meet the eligibility criteria. Or patients with OSFED, which is other specified feeding or eating disorders. You guys might remember this as EDNOS as well, which has rapid weight loss and frequent binge eating or compensatory behaviours. Again, needs to be greater than 3 times a week, and they need to meet the eligibility criteria. So the eligibility criteria is an EDEQ score of 3 or higher, and I'm going to talk to you about the EDEQ in a sec, and 2 of the following indicators. So being underweight with a body weight less than 85%, a risk of medical complications, serious comorbid medical or psychological conditions, an overnight inpatient admission for an eating disorder in the last year, or an inadequate treatment response to evidence-based treatment over the past 6 months despite active and consistent participation. 2.
The question is, what are inappropriate compensatory behaviours?
So abuse of laxatives, diuretics, performance-enhancing drugs,
Purging.
Self-induced vomiting.
Over-exercise.
So any kind of disorder, any eating disorder.
Any behaviour that's designed to compensate, to use up the calories or compensate for what you've consumed.
Yep.
Hang on, I'm coming up the back with a microphone.
Is there a criteria for rapid weight loss? Like, is it a number of kilos in a certain amount of time, or is it just your judgment?
Rapid weight loss, Gabs. Would 2 kilos.
I don't think there is definition criteria.
No.
Percent of what BMI is that? 25 or 21? 85% of expected weight. Is that a BMI of 25?
What's
or
85% of expected weight? The BMI is about 18,
So
is it not?
That's against their norms, right? So we're also thinking about people who are growing when we talk about their body weight being less than what 85% of what their expected weight would be. So we're also thinking about those BMI graphs and percentile charts.
Children, adolescents.
Mm-hmm.
Just in relation to rapid weight loss, you will probably find that person meets criteria simply because they fall they also have compensatory behaviours to increase their rate of weight loss.
These are all part of the DSM-5 criteria for multiple eating disorders, so you can look a bit more in there for the specifics as well. But there isn't really like a standard measure of rapid weight loss. And what the items cover, so as we talked about, the preparation and review of the plans, those are the ones most important for you. And also I've got sort of over there that where people in rural and remote areas do have access to telehealth when they meet the criteria. It also includes the dietitian numbers, the psychologist treatment numbers, and not just psychologists can provide these, so any mental health practitioner who's eligible has those item numbers. And there's also a review built in, which I will show you in a second, with a psychiatrist or a paediatrician at the halfway point. Yep. So unless otherwise specified, these items work according to the existing structures. So like Jan said, the extra item numbers, they're the same rebates as Better Access, except the new medical provider numbers, which have the new pricing. There's no changes to the providers who are eligible. It's for people who are in the community, so not for people inpatient, and that big difference of that 12-month period.
Does Inside Out also recommend psychiatrists with an eating disorder?
Yep, we do have psychiatrists on our database.
With eating disorders?
With eating disorder specialties. With eating disorders on it. Yes, we do. Yeah,
Look,
we do.
and the issue of whether a psychiatrist needs to be involved with an eating disorder is quite vexed. Not everybody agrees that every patient with an eating disorder needs a psychiatrist. But unfortunately, built into all of this is that after 20 sessions with the psychologist, the patient has to have a review by a psychiatrist or a paediatrician, depending on the age, of course. So that creates some difficulties for people who do not already have a private psychiatrist.
So this is your pathway. It looks a bit fancy, but like Jen was saying, so we have that eating disorder plan developed with the GP up the top. They then go to 10 psychological services, and it opens them up for all 20 dietetic services the minute they're referred, so we don't need to worry about the dietitian after that in terms of paperwork. We've got then a 10-session review, so once they've done 10 sessions, not 6, they're coming back to the GP for a continuation. They're then going to another 10 with the psychologist, and then the psychiatrist specialist review comes into play, but there's also a GP review in there as well. So the GP is going to need the report from the psychiatrist, the letters from the psychologist, and the dietitian will probably have sent an initial letter by that time and may or may not have sent their 20-session letter then as well. Then they get the 30 to 40, and then a review, and then the 20 to 30, and then the 30 to the 40, and that's it.
They're done, they're cured.
Okay, so we mentioned the EDEQ in the eligibility criteria. We won't. We have a copy of it on your table, and there's also on the back page how to score the EDEQ. It's available for you on Health Pathways. I want to make a special point about the EDEQ that I've noticed coming up for GPs that I've been working with. There is something called the EDE, the Eating Disorder Examination. It's a very long question
A structured interview.
A structured interview. That's not all we're asking you to do. The questionnaire is this one that's on your table. And if you would like, we have a wonderful part of our website where you can actually fill it in online, and it generates a report and scores everything for you. So you don't need to do all the mathematics involved, but if you want to, and you can have a look at the subscales on the back, you would need to calculate the subscales and then sum and divide those subscales to come up with a global score. And we're looking for a global score of 3 or more to meet the eligibility criteria for Medicare. That is not a diagnostic level. So people might be below 3 and still have an eating disorder, but what we're talking about is eligibility for the Medicare.
Yeah. Can I just say that normally I would get you to do this, but take it home and do it for yourself, because you need to know what your patients are doing, and just let me know if you score more than 3 and I'll give you some advice about where to go.
And I've also put some population norms in there for you so you can compare yourself to what we would be expecting to see.
I would suggest from feedback that I've got that about 50% of you will score more than 3 on the basis of the disordered eating that we've grown up with.
Getting your data, click the thing.
Where am I getting the data from? I'm making it up, of course.
All right. The eating disorder plan. Jan, next slide for me. So we've talked to you about where you can find that. this is what the EDP must involve. We've done the hard work and created these templates, but you're also welcome to do it however you would like. This is what needs to be included according to Medicare. A diagnosis, treatment options and recommendations, an outline of the referral options. So like I said, you can include the psychologist and the dietitian in the same plan, no need for two. And you need to have offered the patient or the carer, when appropriate, which is most of the time, a copy of the plan and some education about eating disorders.
Luckily, we're all used to doing mental health treatment plans, and this is not a lot different from mental health treatment plans. The specialist review is the vexed thing at the moment. Sure, all your patients that have got access to private psychiatrists will have a specialist review at 20 sessions, no trouble at all. It's the public patients who can't get access to psychiatrists that you've got to worry about, and it's probably worth saying them to them at the beginning of their 20 sessions, save your pennies. You're going to have to go and see a psychiatrist privately.
Well,
after
also,
20
Jan,
sessions.
so I've clarified this with Medicare. You can send the person for a specialist review at any point. So you can write the plan, and before they've even gone to see the psychologist, they can go to the psychiatrist and get that.
Yeah, but that's not their
20 to
20
40
session review.
No, but given, well, you know, it isn't their 20 session review, but the psychiatrist can actually give their specialist opinion that the person would need more than 20 sessions.
But we're
at any
talking
point.
about poor people here who can't afford to go to the psychiatrist, so they can only go once.
Yep.
They need to save their
No,
pennies
but that's what
during
I'm
those
saying.
20
They don't need to
sessions.
go at the 20 session mark, Jen. They go any time between session 1 and session 20.
Oh, yes, yes, I see your point. Yeah.
Do we have a list of the specialists who are on the inside out?
We do have some on Inside Out. I'm sure you can also find them attached to the various private hospitals that
There aren't
treat
very
eating
many that are
disorders.
interested in
And they
eating
do have
disorders.
long waiting lists, so I do suggest if
Problem,
you
isn't
really
it?
think a person is going to need longer than 20 sessions, that you start that process as soon as you can.
There's one practitioner in this town who, whenever an eating disorders patient is seen, says, go join a health fund, will you? Because it's so hard to get appropriate services for eating disorders in the public sector.
Timing-wise, if patient have already 2717 or 2715, is there any clash with this? No, so we can do one and then another?
Yeah, it's quite separate from a mental health treatment plan. Yep. Yeah. But I wouldn't suggest that you do it at the same consultation. You might get into trouble, as we've seen
So
this week.
Medicare doesn't recommend concurrent plans, but they all count towards the overall 40 sessions. So if a person has had 10 mental health care plan sessions, they'll only be able to access up to 30 under the eating disorder plan. So no one would be surpassing that 40 sessions regardless of how you do it in that 12-month period.
On the plan, it lists a space where you put actions, record the actions the patient needs to make.
Mm-hmm.
But we were saying we were going to do early intervention and we don't really have a diagnosis. So in actual fact, we do need a diagnosis at the beginning.
Well, this is for the eating disorder plan. So this is for someone who you would be expecting to need to access at least 20 sessions.
You're right, Jane. This
So for
does
early
not really...
No,
Yeah,
so for
these-
early intervention, this is not the plan.
Yeah.
You're right. This
Yeah.
is for people
Now
diagnosed
we're
with an eating
talking about
disorder.
people with established eating disorders.
No, but there is the mental health care plan still, and you could be sending someone for their general well-being because you're already saying, look, something's going on with your eating, something's going on with your coping skills, something's going on that a psychologist might be able to help you with.
Yes. Absolutely.
Absolutely.
That nobody works totally, well, nobody I know works totally in eating disorders. In fact, the ones who are famous for working in eating disorders beg you to send them something else from time to time.
Well, and it incorporates everything. Eating disorders is requires training in
that's right.
everything,
Yeah.
right?
It's really devastating to see nothing but people with severe eating disorders all the time.
So the reporting requirements for the dietitian and the psychologist, the dietitian must send you a first initial letter around session 2 and a final treatment letter. The psychologist probably will send you an initial, but they don't have to, and then they have to send you a letter every 10 sessions for your review. So this is what I was saying before, just for you to keep in mind that mental health providers need to be working in a particular modality, so something that's evidence-based. There's a list of them here. You don't need to know them. The psychologist can tell you that you just need to be checking that they're reporting back to you that they're doing one of these treatments. So that
Probably good from an audit point of view if they say in their letter back to you, I am doing.
No, and of course they should be, but that's for your knowledge. But you don't need to prescribe which therapy the person will be doing, is what I'm saying.
Question, Dave.
How often does somebody just have an eating disorder and not other coexisting mental health issues? And so can the
Never is my answer.
psychologist, he or she able to deal with all their issues, or how does this work out?
Yes, certainly. Yeah, certainly. The eating disorder is that primary or acts as one kind of diagnosis that we're looking at. Eating disorder specialists, psychologists, of course, particularly know about anxiety, depression, and anything else that goes along with eating disorders, and they'll be able to work within their scope of practice. If they feel like someone, say for example, I see someone, it's quite clear that they have a lot of trauma work that needs to be done, I might be saying, hey, they need a specialist trauma person. But we're able to sort of navigate those scope of practice things for ourselves.
All of this information about the Medicare item numbers and so forth is on the website and on Health Pathways. So because we're running right out of time and we need to give Mars a chance to talk, we're not going to talk about that stuff anymore. I just want to ask you what you'd do if Lauren didn't turn up at the dietitian as planned. She didn't. Because this pertains to a question that you asked earlier. What do you do when patients don't turn up for their follow-up appointment? Lauren's sicker now, she's vomiting. You'd ring her up? Good, that's what I like to hear, good on you. Good old-fashioned practice of ringing up the patients if they don't turn up. You need a book though that you write it in, or a computer that you register it on, that this person's due to come back. I've solved the problem by making the appointments in advance before they leave the last consultation, and then I know if they don't come, and I can ring them up straight away. Anybody got any other things that they do? Does anyone do nothing? Okay, a recall. Who does the recall? Your practice nurse? Yeah, okay. So there are two options. I think the only message I want to say is you can't do nothing. You've got to follow it up when you've arranged a follow-up appointment for somebody in that sort of situation and they haven't come back. The bit about Lauren here was about failing to examine the patient, and I can tell you lots of stories. Lauren had some vaccinations and the practice nurse noticed that when she gave her travel vaccinations that she was very skinny and sent her back into the GP. That was a save, but I can tell you a story about a friend of mine whose daughter got very unwell even though she was seeing a psychiatrist for psychotherapy weekly for 2 years, and she was able to hide her increasing low weight, that's the wrong way to put it, she was falling apart really, and the psychiatrist didn't notice because no one was weighing. You need to physically examine the patient, which is why everyone needs a GP, and every GP needs to examine people. So Lauren has come back from her overseas trip with a BMI of 17. She's getting sicker. This is not from my imagination. This is actual things that happen to people. In fact, she's come back preparing for an overseas trip. I'm getting ahead of myself. But she did come back from her overseas trip with some significant problems with her health. Now, on this slide are the criteria, the things that you need to do for acute medical assessment and the things that you need to do over the longer term when you're managing someone with an eating disorder. And I don't think I need to tell you any of that, but I do want to reinforce the need to do the cardiovascular assessment on somebody who's got an eating disorder, whether they're underweight or not, because they can become unstable at normal weight if they're doing lots of purging. So each time you see somebody, you need to know what their rate and amount of weight change is. You need to know what their pulse and blood pressure lying and standing are. That's incredibly important because they may well be normal if you just sit them in the chair beside your desk and take their pulse and blood pressure. You need to know about their cardiovascular stability. You need to check their electrolytes, and there are some tricks for the unwary in that. You need to do an ECG every now and again to check their QTc interval. Now, in my traps for the unwary, medical traps for the unwary, be aware of tricks that lead to falsely increasing their weight, like water loading and other tricks like sinkers in the vagina and various other things that people do. Always take their clothes off to weigh them. if you're doing the weighing. The dietitian, if she's doing the weighing, will also take their clothes off to weigh them. Oh, how do you get around the tricks? Don't answer that, we'll talk about it later.
Oh, we get around them, Jen. Don't worry.
Don't miss hypokalemia that's been hidden by traumatic venesection or dehydration. Yeah? Don't misinterpret electrolyte disturbances when they're actually as a result of overhydration. You should do the blood test at the same time as you weigh somebody so you get a sense of whether that weight's real or as a result of the overhydration in preparation for the weighing. Don't mistake starvation-induced thyroid suppression for a thyroid disorder. I have had the occasional very thin patient put on thyroxine as a result of somebody misinterpreting that. Abnormal liver function comes with starvation, as does elevated amylase. So don't go on a wild goose chase for causes of that if you see it. Polycystic ovaries appear on the ultrasounds of people who are very thin with eating disorders because their ovaries regress to a juvenile state and they look like polycystic ovaries. Don't diagnose PCOS and tell them to lose weight. And not realising that neutropenia occurs as a result of starvation. People who are severely underweight are immunosuppressed. I had a patient who went to an Asian country and got pneumonia, but because she got no fever and didn't have an elevated white cell count, her condition wasn't taken seriously, and she was thin because that was normal in this Asian country to be thin like she was. So it was missed, and she spent 3 weeks with pneumonia, quite severe, untreated and out of hospital before somebody woke up to what was going on for her. So these are things that you need to bear in mind with people once they've got established eating disorders. Lauren didn't come back after she went to Thailand, so we chased her up with a phone call. After the holidays, she came back, but her weight was stable. This is a different story about Lauren. She wants a sexually transmitted diseases check after visiting Thailand. Now, that's perfectly reasonable. Are you going to talk to her about her eating and her weight in the context of that? Yes, you are, because you're not going to let that opportunity pass. Lauren doesn't go back to the GP after Thailand. She goes to the dietitian to help lose some of the weight she put on while she was away. What do you do, dietitian?
Well, hopefully by this point you've referred them to an eating disorder specialist dietitian who will not have a bar of helping them lose weight. And also most dietitians in this case would set up a non-negotiable or have already set up a non-negotiable with the client at the beginning of treatment to ensure that they are seeing their GP as part of their treatment plan. So you would be really pulling on here to ensure that they are seeing their GP regularly.
So Lauren, in another scenario, has gained weight while she's away and she's madly vomiting to try and get it off again. That's another issue, isn't it? So that brings us to the criteria for admission. Now, you probably all know that a BMI of 14 or less is probably not ideal and should be a criterion for admission, but it's very difficult to get anyone into a public hospital even with a BMI of less than 14 without some of the other things going on. So bradycardia, postural drop, hypokalemia, hypothermia. That's what my friend's daughter finally went into hospital with when she decompensated. Hypothermia. So taking the temperature of someone who's quite thin is an important thing to do too. Intercurrent infection, like my girl. Don't forget their mental health. Suicidality and psychosis are reasons for admission in an eating disorder. Intractable purging. I've had patients who purged all day. Every time anything passed their lips, they would purge, and it would go on all day. And failure to respond to outpatient care is another good reason for admission. Who's most at risk? The preteens are really at risk because they can be destabilised very quickly. Anyone who purges, uses laxatives or diuretics is highly at risk, irrespective of their weight, but particularly if they're low weight. Anyone who's severely underweight, especially if they purge, am I repeating myself? I think I am, but I really want to make that point. Because someone who purges and is underweight doesn't have bulimia, they've got purging anorexia by definition, and that is probably the most dangerous thing of all. And those who are losing weight rapidly regardless of the starting point. Now, what if Lauren was 12 and not 19? Would that make a difference to the treatment pathways?
It changes things for us because family-based treatment is the current gold standard treatment for children and adolescents with anorexia nervosa, but involvement of family is particularly key for this group, and involvement of carers generally is important, but in particular we're going to be working with a whole family approach.
And Westmead does the main family-based therapy in Sydney, and they also train the family-based therapists that are out in the community. The real problem with family-based therapy is not all families can do it, but because it involves every member of the family. So
that's true for Maudsley, but there are other family therapies that we might consider if Maudsley isn't a possible approach.
Okay, so Maudsley was the first kind of family-based therapy that existed. And look what I've done.
There's his face.
There he is. I've actually got to the end of my slides before the time's up. I'm going to hand over to Mars to let him introduce himself.
Hi, sorry, that photo's really zoomed in, so I just always laugh when I see that photo. Oh, sorry. Oh, this mic's not working, is it?
No, it's just for the video.
Sorry, I'll try to speak louder. Let me know if you can't hear me. So my name's Mars. I'm the eating disorder coordinator for Sydney Local Health District. So I just wanted to acknowledge the traditional owners of the land on which we meet and pay my respects to elders both past and present, and those attending today. And also want to thank PHN for this event and inviting me here, and the presenters for squeezing me in. So I just wanted to go through today what my role is. I've been in this role for 2 years now, and I think I sort of know what it is now. So it's a very unique role, I suppose, and I wanted to go through that really quickly. What we're doing in terms of the eating disorder service plan locally in the district, and then look at some of the services that are available for child and adolescents and adults in the district. So my role, the role is, the small part of the role is a lot of it is about support for the services, support for the clinicians. GPs certainly is a group of clinicians that I provide support to as best as I can. Happy to be contacted anytime. The other large part of my work is with the eating disorder service plan, and I'll go through what we're doing with that in a second very quickly. Part of it is improving system capacity, so service development. The other layer of that is workforce development and training opportunities. Inside Out Institute we work with quite closely. Lots of amazing training opportunities coming out and exist at the moment, online and face-to-face, and also research evaluation. Yep.
When you say support for local team services and clinicians, I'm a GP, what can you do for me?
So to give you an example, some of the things that I have done is with some of the GP practices I've gone and provided some in-services. So any of the things discussed today as well, I'm more than happy to go through on the phone or face-to-face, or come across to your practice and provide an in-service if you want me to. More than happy to do that. I do that for all the services across the district throughout the year, but I'm definitely happy to do that for GPs as well. Also, with some cases we have case conferences and really pulling the team together. There's a lot of emphasis about the multidisciplinary team, which I would like to also second, and think is the most important aspect of care in eating disorders. And so sometimes I will try to pull all the clinicians together to the best of my ability and do some case conferences for when we get stuck with some of the patients in terms of their treatment or clinically. So that's kind of what support can look like. But I'm very open to suggestion and helping in any way I can. There are coordinators on the Inside Out Institute website. Our contacts are on there. So there's one coordinator in each district. So I'm it for Sydney Local Health District, but there's one in every district. South East, obviously missing today, but I used to work quite closely with her, but she's moved on to another role at the moment. So that's vacant for the moment.
So can South East people ring you?
From a GP's point of view, I'm not too concerned about districts. I think if you've got a concern, give me a call. If I can't help directly, I'll do my best to link you in with someone who can. whether it's another local coordinator, if it's Northern District or wherever it is, happy to do that, or just go through whatever on the phone anyway, regardless of which district you physically sit in. You're going to have patients obviously crossing everywhere.
Each
So
district also has things like steering committees or medical and psychiatric committees with people sitting on them that might.
I'm trying to think
Yeah.
of it in terms of what a GP needs. You know, if I had a patient, or one of us had a patient that needed admission, and we didn't know what to do, would you be a good person to ring?
Yep.
Okay.
Yep.
There you go.
So if you get stuck at any point in time with anything, just to keep it simple, and if you're not sure, you've got an eating disorder patient, happy to be called and go through individual cases with you. Most people sort of look at me funny when I say that, and they're like, you're going to be inundated with calls. I do it all the time. I've been saying this for 2 years. I don't get flooded with calls. I'm happy to be contacted and discuss patients with you.
Is the contact available on Health Pathways?
It should be once we update it. It's not fully updated yet, but we're very close. Yeah. I think I got it on one of the slides. Yeah. Phone number or email. Monday to Friday, 9 to 5. Email 24/7. So I won't bore you with this too much, but this is a basic structure of what we're doing across the whole state, and just wanted to let you know that we are doing as much as we can with services in developing them. There's a statewide eating disorder service plan. There's a local eating disorder service plan for our district, and branching off from that are our models of care, which we're working on. We're almost finished that at the moment. And then beyond that, we're looking at guidelines and processes. So an example of that is our emergency department protocol that we have at RPA. That's quite clear. There's a very clear process and pathway for that, which I'll talk about in a second as well. That's kind of what we look at as a model, I guess, in terms of treatment for eating disorders in our district. As a spectrum of care. It's sort of based on step care as well, PHN step care model. We've sort of drew some inspiration from that. But basically you've got your health promotion and prevention sort of strategies at the bottom, primary health care, secondary health care, community, intensive outpatient settings, inpatient care, and then your specialist tertiary statewide services. So it's a steps model, so it's not about patients needing to going up in stages. It's whatever the patient needs at that point in time, they access one of those services. We do have gaps along that, mainly in ambulatory services, which we're working on at the moment. We've got some meetings and various things happening across RPA and the tertiary services as well.
By which you mean outpatient?
In outpatient services, yeah, which we're calling ambulatory from a terminology point of view.
It's a modern term.
Yeah. Yeah. So, just got 2 slides on services and pathways and my contact details at the bottom. So, with child and adolescents, in terms of that primary ambulatory care sort of umbrella, GP, psychologists, dietitians, psychiatrists, private hospitals, Butterfly Foundation and Headspace. We work quite closely with Headspace as well. Community health, we've got Child and Family Health Services, Youth Block and Rivendell in Sydney Local Health District. Rivendell Outpatients is quite established from a care pathways point of view at the moment. They'll do assessments, they've got an expert team working there. And then there's Sydney Children's Hospital at Westmead is the tertiary statewide service for child and adolescents. Youth Point is a website that's quite useful, has a lot of contacts on there, and a whole lot of services. The health system's obviously incredibly complex, and I try to do my best to make that as easy as possible if you give me a call. Adults, somewhat similar. Primary ambulatory care is pretty much the same. Community mental health, we've got 5 in the district: Camperdown, Redfern, Marrickville, Canterbury and Croydon. They provide care coordination, they provide assessments. There's sort of that next layer of care. If you patient's gone through an eating disorder plan, they're becoming more unwell, they get a bit stuck, that's potentially an escalation option. And then obviously if they become really unwell and needing a medical or mental health admission, particularly for medical, RPA is quite well established as for our district. So if there is a patient that lives in Sydney Local Health District who's medically unstable, RPA is the hospital to send them at the moment. Working with Concord Hospital at the moment to open up that pathway too, but for the moment RPA is happy to take all patients in the district. The critical step for that that's really important is the phone call to the endocrine team at RPA. So if you call Switch, RPA Switch, ask for the endocrine eating disorders team. If they're not sure who that is, anyone on the endocrine team will know, so they'll link you in with them. Yep.
Why is it split between medical and mental health? Why isn't it a combined service for both?
Yeah, that's a good question.
Well, yes, I mean, it seems crazy, and also, how does the crisis team fit into this? So the mental health access line after hours for emergencies, because it's a mental health disorder. I'm not going to say primarily, but it is a mental health disorder as well.
Yeah, yeah. So when a patient gets that unwell, whether medically unstable or psychiatric sort of parameters, I suppose, needing a mental health admission, the pathway is still pretty much the same. It's RPA, the emergency department. They have mental health experts working in the department, in the emergency department. And when a patient is flagged with an eating disorder, they'll automatically be called in as well. So they'll get a mental health assessment as well while they're in the emergency department at RPA. And the endocrine. So what will happen if there's an eating disorder patient that's if you make that phone call with the endocrine team at RPA, they'll put the patient on the expects list in the emergency department. As soon as a patient comes in, they'll be on the expects list. They'll be like automatically endocrine mental health.
See, the thing is they've got to be medically unstable before they get a psychiatric admission. Well, medically stable. So you have to ensure by going through the endocrine team that they're medically stable, safe, to go into the psychiatric. Yes, it's a big problem.
It is a problem in health.
But that's put into camps.
Yeah, there is. So we're slowly working through that as well. There's a mental health CNC now that works on the medical wards. The RPA endocrine team regularly visits the mental health wards and provide a consultation service there as well. And so there are more links that are happening, but yes, I agree there needs to be more integration, yeah, which we're working on, and we're aware.
The district has kind of naturally developed a team that would like to sort of receive these patients and lead the care, and it is dependent on hospital, on which hospital who does that, and at RPA it's the endocrine team.
Yeah.
The other big crack in the floor for eating disorder patients is that transition from adolescent care into adult care, and that's where we come in. We've got to keep a close eye on them to make sure they get a team once they're an adult that can look after them and they don't sort of disappear down the crack.
And there's a service in RPA for that.
Yeah, so RPA...
What was the trapeze or something that goes from the children's hospital to the children's health pathway?
Yeah.
Adolescents, yes, transitioning across to adult care.
And in terms of medical inpatient setting, again, 16, 17-year-old would be RPA and they'll be seen in the adult setting. Yeah, which you may or may not agree with, but that's kind of the cutoff. Yeah. Yeah, 16, 17 is considered adults in terms of this health system in the medical wards, which is a bit different too.
Inpatients are now separated from the rest of the psychiatric inpatients, aren't they?
Separated in which way?
Physically separated, or are they still in the same ward as the rest of the psychiatric patients?
So if they're in the general mental health wards, they'll be with everyone else. So depending on where and why they come in. So if they meet the mental health admission criteria, they'll be in a general mental health ward. The specialist eating disorder service inpatient unit upstairs in level 5 is more of a planned admission. So that one requires a referral form. Happy to go through that with you as well, because I do intake once a week for that service as well anyway. So for all the local patients, I generally just take all the phone calls and do all the triaging and intake and all that sort of thing. Where possible, I'll try to look at some local services if there are some options. And if it's complex enough or needing a tertiary level service, I can go through that with you as well. So my name and numbers on the bottom there. I'm more than happy to support in any way I can.